everybody. It's a pleasant Sunday evening, and today, April 11, is World Parkinson's Disease Awareness Day. April, of course, is celebrated as the month for awareness of Parkinson's disease. But I really wonder whether we celebrate a disease or are we creating awareness for this disease. Unfortunately, amongst the neurological diseases, Parkinson's disease is the forerunner and is most likely to be the most common neurological disease in the days to come. It is second only to Alzheimer's disease, which is a neurodegenerative disorder. So truly speaking, today we are challenged by a disorder which is Parkinson's disease, which is degenerative, progressive, and has no cure to our knowledge as on date. Today, as a concerted effort, we have India's top experts to dwell on this topic in the field of neurology. I, Dr. Puja Dewan, your show host and moderator for this show, present to you our two panel experts, Dr. Mohit Bhatt and Dr. Satish Khadilkar. I must introduce each one of them, but before I move on to the introduction, I welcome you, Dr. Bhatt, to the show.
Thank you so much.
And Dr. Khadilkar, you as well.
Thank you.
Dr. Bhatt is the director of the Department of Neurosciences at Kokilaben Dhirubhai Ambani Hospital and Medical Research Institute in Mumbai. And Dr. Khadilkar is the dean at the Bombay Hospital Institute of Medical Sciences at Mumbai as well. Both of them are neurologists, and we are fortunate that both of them have also had a good old years of training and born hobby and camaraderie together. And today we have both of them with us. Dr. Mohit Bhatt, of course, has keen area of interest in the disease, Parkinson's disease itself, as well as Wilson's disease. And he is one amongst the foremost practitioners of movement disorder in India. In fact, it is he who brought it forth as a movement disorder consultant in 1992 and is credited with initiating botulinum toxin injection for movement disorders in Mumbai in 1991. He also went on to take interest in Wilson's disease and has, to his credit, an international recognized classification to measure the disease load in Wilson's disease. Deep brain stimulation surgery for Parkinson's also has been established by Dr. Bhatt in India for this disease. Of course, he also has a layman society wherein Parkinson's disease patients are his followers, and he is contributing to the awareness of these patients as well as the caregivers. Dr. Satish Khadilkar is the dean currently in the department and the professor and head at the Department of Neurology at Bombay Hospital. He is the president of the Indian Academy of Neurology and the past president of Maharashtra Association of Neurology and Bombay Neurological Association. And of course, been the editor-in-chief of the Annals of Indian Academy of Neurology previously, fellow of the Royal Society of Medicine, London, and National Academy of Medical Sciences, and so many more. Welcome to the show, both of you.
Thank you.
Thank you.
Just one line brief that I would like to hear from both of you. Dr. Bhatt, anything that you'd like to add to Parkinson's disease as on the day-to-day that you hear as an esteemed panel?
Well, this is a very important day for all doctors and patients who deal with Parkinson's disease. This is a day when this is the birthday of James Parkinson, who described this disease, and he wrote a book called The Shaking Palsy, and it has stood the test of time. And his description 200 years ago was so accurate and so incisive that very little could be added to his clinical description. And so it is correct that we call this disease as Parkinson disease after James Parkinson. And so as the hour progresses, we shall discuss clinical features and other aspects of Parkinson disease.
Truly, sir, the essay on the shaking palsy that he wrote, where he so beautifully described to a layman that so slight and nearly imperceptible are the inroads of this malady, and so extremely slow its progress, that it rarely happens that the patient can form a recollection of exactly the precise period of its commencement. The first symptoms are the slight sign of weakness, with a proneness to trembling, and in some particular part, and sometimes in the head, but most commonly in one of the hands and the arms. And if a patient in retrospect was to really read this, once diagnosed with Parkinson's, I mean, it cannot be more correct than what it is. Dr. Khadilkar, over to you.
Yeah, I think this is a very important day indeed, because it just sort of enhances the awareness of this problem. And like you started saying, like you opened the talk, it is a common disease now. And as our longevity goes on increasing, in India, we're going to see it more and more, because in certain ways, it's a disease that links with longevity. So it's only most appropriate that on this platform, we're discussing this today to try and exchange ideas and make patients' quality of life better. So it's the most appropriate time to do this. Yeah.
You know, as a lover of art on the show, I cannot but help mention that the color for Parkinson's has been described with the red tulip with a fringe of white as the official symbol of Parkinson's disease in 2005, you know. But sadly so, to add some brightness and hope, we have a red tulip here. And it was incidentally developed by Van der Wereld, a Dutch horticulturist who himself had Parkinson's disease. And then, of course, he dedicated it and named this tulip onto James Parkinson. But as Dr. Khadilkar very correctly mentioned that, yes, we are now a society which sees more of geriatric patients, and longevity of life is a boon, but it brings with it certain disorders. And Parkinson's disease is one amongst them, where it is more common in the elderly, and usually the age of onset is 60 and around, and the rates rise from 1% in those who are over 60 years to nearly 4% in the population who is over 80 years of age. Dr. Khadilkar, would you like to add some more information to the epidemiology and statistics of this particular disease?
Well, I think, like you said, it's primarily linked with the aging. But it doesn't mean that other people don't get it. So I think you see it everywhere, but you see it more and more as you see older population. And like, just to reiterate, how much our longevity has increased is phenomenal. I think 20 years ago, it was 47 or something around that. And today it's taken a leap of 20 years. So I think there is no...
67.
Yeah. And it's going to grow as we sort of win over our infections and we sort of get control of TB and malaria and stuff. We are going to see diseases that come with age and with degeneration. So I think we're going to see more and more. Our ability to diagnose will become more and more, because there are more neurologists now in various parts of the country, and there will be more neurologists. Physicians can diagnose it more. So I think we're going to see more early and more diagnoses, and we're going to see more cases. So I think we are going to really have to look at this problem at multiple levels in the society and the medical fraternity.
Dr. Bhatt, of course, younger people also get Parkinson's disease, don't they?
So yes, the average age of Parkinson's disease is around 60, and that's the garden variety Parkinson's disease. But when they get it below 40, we call them young onset Parkinson's disease. And that number is much smaller. If they get it below 20, we call it juvenile Parkinson's disease. So you can get it in less than 20, you can get it less than 40, but that number is very small. The majority of the patients, I would say 85% of the patients are in the 60-year age group. So, and then the prevalence increases as you get older.
In fact, from whatever I have known of the good old days that I read medicine, of course, I never read neurology, but whatever little medicine that I read, I mean, there is a role of genetics, there is a role of head injury, there is also a role of diet. So, Dr. Bhatt, would you like to dwell some light into genetics and Parkinson's. I mean, people are really scared when they see somebody who is elderly and especially a progressive, debilitating form.
So, there's a big controversy regarding what causes Parkinson's disease. Some people feel that research site feel that it is environmental reasons that cause Parkinson's disease, while there's a whole school of thought that thinks it is genetic. And there is a school of thought that says that it's an ecogenetic, in the sense that there's an environment which changes the genetics and produces Parkinson's disease. But there are some genetic mutations which are prone to produce Parkinson's disease. But so if a patient was to ask me that I have Parkinson's disease, what are my chances of my children getting Parkinson's disease? Then the chances is very small. But what is the prevalence of another member in a family with Parkinson's disease? Then it is higher than the general population. It's around 10%. So there'll be a higher, another member may have Parkinson's disease, but from multiple members having genetic Parkinson's disease is extremely rare. And then there are some genetic mutations which produce that variety of inherited Parkinson's disease. The garden variety of Parkinson's disease is not a genetic disease. Your chance of transmitting the disease to your children is very small.
Dr. Khadilkar, yes, sir. Please add.
Can I add a little to this,
yes,
the
sir.
genetic
Please.
thing? Like Dr. Bhatt said, majority is not directly genetic. Meaning, I'm just sort of explaining that a little bit, what he said. There are monogenic diseases, meaning you have a clear known gene, you have a clear known transmission, and you have a familial disease with recessive, dominant, X-linked, mitochondrial, whatever type of transmission. But then there are diseases that are digenic or multigenic, where it's very, very difficult to know what is the role of genetics in that disease. But the fact that majority of the standard late onset Parkinson's disease patients do not have an inheritance as we would expect, so to say, the disease is not inherited, they're very likely not monogenic diseases. But there will be some propensity. And that's why the chances of a family member getting, like he mentioned, is a little higher than the community. So it's a kind of not a straightforward genetic disease in most of the patients, but there is some hidden influence. Yeah.
True. In fact, whatever little that we used to understand that there is a portion of the brain which is called substantia nigra, and there's a loss of nerve cells, and those nerve cells are responsible for producing dopamine, a chemical which is very important, is what we understood. Dr. Bhatt, would you like to add something?
So there is a part in the brain which is called the substantia nigra, which is in the midbrain, and and that is the area which produces dopamine, or the chemical that allows us to move around freely, allows us spontaneity of mind, the creativity of mind. So the dopamine is produced there and supplied to different parts of the brain. In Parkinson's disease, there is a degeneration of substantia nigra. So the factory cannot manufacture enough dopamine. When there is dopamine is not manufactured enough, patients become slow. They think slowly, they move slowly, they develop tremors, and they also some of them can get depressed. So a whole range of symptoms are created because of deficiency of dopamine. And this deficiency happens because of degeneration of substantia nigra.
They say head injury is also responsible. We have certain very famous personalities about whom we read even in our school, in the school curriculum, and one amongst them was Muhammad Ali, the famous boxer, Cassius Clay. And it's well known that around the age of 38 years of age is when the early symptoms of Parkinson's, affected him. So today, when we read literature, we are yet to understand, is it early onset Parkinson's for him, or was the head injury responsible for it, or was it independent? Dr. Khadilkar, anything that you'd like to add to it?
No, there is this situation where somebody who gets repeated head injuries, as the example you gave of Cassius Clay, people get again and again and again, and little by little, some changes occur in the brain cells which produce the dopaminergic output. And therefore, with repeated multiple head injuries, this has been described, the so-called dementia pugilistica. They get cognitive changes also, and they get Parkinsonian also. But whether a single straight head injury can later on lead to a Parkinsonian syndrome, it's not that common. There's an occasional patient whom you see, but in such a patient, you always wonder whether there is more at play. So it's multiple repeated head injuries where the association has been well known. Such patients are very, very few.
Yeah. In fact, when we read literature, it's scary to hear that, there's so much of environmental pollution, especially pesticides. That's one amongst the known elimination factors which you could keep away from. And I wonder, with so many mosquitoes around and so many of anti-repellents and so much of fertilizers and pesticides, how far are they responsible? Dr. Bhatt?
So, well, there has been a theory earlier that pesticides are responsible so there has been studies which showed that farmers who used to use pesticides had higher prevalence of Parkinson's disease compared to farmers who didn't use pesticides. But there has never been a clear proof for this. I did a study where we looked at all the workers who spray pesticides in our homes, and none of them had Parkinson's disease. And these workers were exposed in a very large quantity. So these are all epidemiological studies where they try to find cause for Parkinson's disease. And this has been the research going on in the 70s and the 80s, where search for cause of Parkinson's disease was a very big game and a very big research project. So this is one of them, but there has never been a 100% proof that pesticides produce Parkinson's disease, but it is
as a layman, every person says, I don't want to be affected by a disease, and prevention is better than cure. And when you are dealing with a disease which is progressive and for which a cure is not found, a common man is going to first ask these questions. That is why I dwelled onto these pointers at length. But since you did make a mention of research, I must share with my audience that the August panelists that we have, Dr. Bhatt has over 100 peer-reviewed scientific publications, multiple book chapters, so many invited presentations at national and international conferences. And so does Dr. Khadilkar. He has, to his credit, 6 books, 43 book chapters, and 150 publications in national and international peer-reviewed journals. How do you, the two of you, find time to really follow the passion of, the field of movement disorders? And have you people done any relevant research or written chapters for the audience and for the doctors who would be today listening to the show? Dr. Bhatt?
Well, I don't think I have written a chapter or for the audience, but which I can say. But most of the scientific work has been very movement disorder related, which is not meant for lay public, but it's mainly meant for our scientific papers. So I am sorry, I can't tell you a reference that you could go to and which would help.
But I can tell the audience that Dr. Bhatt has started a lay society to help patients with Parkinson's disease, that is Parkinson's Disease Foundation of India, and it is the largest and most active society to look after patients and their caregivers. Dr. Khadilkar, what about your contribution?
I'm going to make a general comment on
Yes,
medical writing in India, if you would allow me.
Yes,
See,
of
basically
course.
we are clinicians, and therefore most of us do clinical research in whatever is our area of interest. Like we see patients, we come across some peculiarities, and then we try and correlate those peculiarities. So most of the work that you will see from most of us in whatever is our field will be clinical, and of late some clinico-genetic. Because genetics has now really taken in a big way in India. So pretty soon, I think you will see more papers from all of us neurologists, which have genetic basis as much as the clinical basis. As of now, it has been the clinical work. And what was your second question? Sorry.
Sir, I'll move on. What I was wanting to now dwell into is the presentation of this disease. Yeah. And yes, of course, the primary Parkinson's disease symptoms, tremors, rigid muscles, slow movements, that is bradykinesia, difficult balancing, which may be mild at first and gradually becomes more intense, debilitating, is what we are all familiar with. But when we when we get to hear from you clinical practitioners the exact presentation of this particular disorder, how the patients come to you and how they present to you. Dr. Khadilkar, can you enlighten us on that?
You mean the early features?
Yes,
early
sir.
features of the
Yes,
disease.
sir.
Yeah. Basically one of the features that we need to talk about is the tremor. And the second is slowing. And I think as a neurologist, as you train your eye, so to say, you start picking up that little slowing as the patient starts coming into your room. In fact, most seasoned neurologists will tell you this, that as the patient comes into the room, that's the best time to catch his little slowing, that little blank face, the lack of blinking. Once he familiarizes himself with your room and settles down and starts talking to you, that thing may go away. So I think some early observations can pick up the slowness, which is usually the facial expression, blinking, activities. And then as the disease progresses, it becomes very, very, very obvious because it's one of the symptoms that relatives say is taking more time, patient realizes it's taking more time. And second, of course, is the tremor, which is for everyone to see. Yeah. What would you say, Mohit, is the earliest that you see, shaking or slowing?
I think both. Some patients will come basically with, they say that my hand has started shaking, especially when I hold the phone or when I'm sitting my hand. Sometimes what happens, the patient has not noticed, the family member has noticed that there's a tremor. The patient is not really bothered by it because the tremor is seen some critical angle, especially when the patient is walking. And so that is the presenting feature. And the second is slowness. Slowness comes as patient says, my handwriting has become small. I take longer to write. I'm taking slightly longer to dress. Or they may say that when I'm walking, there's a slight drag in my right leg. Or if I go for a walk with my wife has now walks faster than me. Before we used to walk together. Now I can't keep up to her. So these are very early subtle features and symptoms of Parkinson's disease. In fact, it's very nice to listen to patients, their early symptoms and diagnose the disease. So it's a very clinical disease. So astuteness of a doctor depends on how much importance you give to these little symptoms that patient is going to complain.
And how fast does Parkinson's progress in the patient's life?
Well, Parkinson's, so I always tell patients that when you come to me and if you're 60-year-old, then we are going to be friends for 40 more years. So a good treatment, patient should live a normal lifespan and have a fairly good quality of life. That is, we do not, hope is a very important part of life. And casually also, I would not want to take that hope away from a patient. So most patients will live more than 20, 25 years after the diagnosis of the disease. So now the new dictum is that patients are going to live a full lifespan, even if they had the disease or they didn't have the disease. That is the impact of treatment. Treatment has completely changed the management of Parkinson's disease.
It is so heartening to know this, but once you have mentioned about quality of life, sleep is an essential part of the quality of life as well. Dr. Khadilkar, Parkinson's does affect sleep, does it not? Can you highlight?
Yeah, I think a certain proportion of people with Parkinson's disease does have problem with sleep, and it depends on what sort of molecular pathology is there for them. And there are different molecular pathologies. But sleep disturbances are very common. They tend to get fragmented sleep. They tend to get sleep movements in the sleep. They may enact their dreams. They may get up. They may shout. So sleep-related issues are pretty common, and they can be part of the problem of quality of life.
Can I just finish the sleep bit a bit, which is very important, I feel. That as you become slow in the daytime, you also become slow in your sleep. So patients sometimes may have difficulty with turning in bed. If they get up to go to the bathroom, they are very slow. So this disturbs their sleep because they can't turn in bed like before. And so that is the role of treatment at night. So we do give treatment at night to improve their quality of sleep. The quality of sleep.
In fact, when a patient is suffering from any kind of movement disorder, somehow the society does not take to it with as much affinity. And there are these stairs, and then you yourself can see that you are progressing. So the sleep gets disturbed. So anxiety, depression, all seem to come in. So there are these leading questions by the patients as well as the physicians here would certainly like to know that is Parkinson's related with depression, anxiety, or is it that the disease is affecting the psychology per se? Dr. Bhatt.
That's a very good question. I think both are affected. The moment you get a diagnosis, you feel it's a downer and patient would get depressed. The second thing is that a lack of levodopa or reduced levodopa also produces depression.
I think we just had a break in the connection. Dr. Khadilkar, do you like to add something?
Yeah. Like Dr. Bhatt was telling,
I think we just had
anger, animi, the sense of impending doom. Something is going to go wrong.
Dr. Bhatt, we had lost your connection somewhere in between. I had invited Dr. Khadilkar to join in to the discussion. Would you like to, review your answer and go on?
Mohit wants to say the last 3-4 lines again. Yeah, last 3-4 lines again.
Mohit. So we are talking about depression and anxiety, right?
Yeah.
So as I said, that the diagnosis of Parkinson's produces depression. It also makes patients anxious. But the biochemical changes, the loss of dopamine also adds to depression. And so there's a biochemical depression, there's a depression of the diagnosis, and there's anxiety. You are worried, what is going to happen tomorrow? The sense of impending doom. And am I going to live long? Am I going to get disabled? So this also requires a lot of treatment. You need a counselor, you need a psychiatrist at times, and a good neurologist should be able to help the patient.
And then there is this fear in the mind of pain.
Can I just say something? Yeah.
Please.
See, basically, the diagnosis is one of the issue. When you make a diagnosis of a disease, immediately they have now access to the literature. So making a diagnosis of, say, Parkinson's disease has a tremendous impact on people now, as compared to 10 years ago, 20 years ago, when access to literature wasn't that much. So there are times when I do not say that this is Parkinson's disease, but say, look, there is a shaking and we will have to look at it. So the diagnosis has that negative impact. And you may find this very surprising, or doctors may find this very surprising, but making a diagnosis of migraine also has a negative impact than saying you have a particular type of headache. So I think how to project it to them also is something that you learn.
I have seen so many patients in and around me in very early phases of just a shaking movement or a shaking disorder, and they go to the doctor. And as they say that, as Dr. Bhatt has said, that you have to present the truth, but then you may take your time and you have to be sweet and soft, because if it's there, it's going to be there. So initially, just to hold on to their confidence in you. There is a lot of talking that you do, but somewhere I have also observed that a chunk of these patients sometimes get so reassured, they just don't come back for almost a year or two there and after, till there is somebody who brings them back because they are sure that it was not Parkinson's. And somewhere along the line, it's also been seen that they will go to alternative complementary medicine. And even if it is a simple pranayam, maybe that's the cure. So I present to you another question, that is, does meditation, de-stress activity help in slowing down the progress of Parkinson's? It's a loaded question to both of you. Dr. Bhatt, you may like to take it first.
Okay, so I will answer this. I'll answer this. There is no scientific proof that meditation, exercise, all these things slow down the progress of Parkinson's disease. So scientifically, the answer is a no. Does it help? Of course. If meditation helps, if exercise helps, and if patients feel more relaxed, ultimately we are here to treat people. And if anything that helps patients, we do encourage patients to relax. We do encourage patients to exercise. So they have a certain amount of medicinal value but there's no scientific proof that it slows down the progress of the disease. And to the previous question that you were answering, I think it's an art how you break the diagnosis to a patient.
True.
You cannot hide the diagnosis, because today, if a patient is sitting in a bus and a neighbor sees his hand tremoring, he'll start talking to him and giving him advice. So, in India, people talk very freely. The moment they see disability, they start discussing it. And people love to come into your personal space. So you can't, to not tell a patient the diagnosis sometimes keeps him in a sense of suspense. So it's an art how you break the diagnosis. And that's why guys like us are required.
Absolutely. I think for every patient, the doctor-patient relationship is different. What you will tell to one patient will be different from what you will tell to the other. And that you gain only by years that you spend in clinical medicine.
Yeah.
So that's where I think older guys are better than younger guys, even though they all can diagnose Parkinson's
The wisdom
disease.
of experience, sir. It's always appreciated.
The grey hair, the usefulness of grey hair.
Graying can start as early as 20s, like juvenile onset of Parkinson's. That's not justified. So wisdom is wisdom.
I would still prefer a black beard to a white beard.
The other thing about one more comment about physiotherapy. It also gives them something to do, and they feel that they are participating. So meditation, physiotherapy, all these also help in that manner. Let's see, tablets are taken 2-3 times a day in 1 minute. Rest of the time, they have nothing else to do. So by doing this, they get more involved in the way they are. And I think a lot of them like it. So that's another way it helps. Even though, like Dr. Bhatt said, there isn't any scientific proof to say that it sort of slows down the progression of Parkinson's disease.
There is always hope to hang on to, but they say that there is no exercise prescription per se that is right for every person with Parkinson's. So be it be biking, running, yoga, Pilates, dance, weight training, non-contact boxing, name it, Tai Chi, they do have positive effects is what they say. So when patients ask about exercise and the role of Parkinson's, I mean, we have dwelled upon meditation and other things, but exercise per se, Dr. Khadilkar?
Basically, we have to understand what is the exercise doing. Basically, in this particular condition, certain changes occur in the posture, the way in which their hands are held, the way they handle their balance, the way they handle their movements. So certain specific physiotherapy regimes can help them improve that and therefore reduce the symptoms of the illness. So that's one part. Second is that they don't move their joints through the whole range because they get flexed and remain flexed. So moving them and not letting them freeze, so to say, is the other thing that it does. But like you started off saying, every patient is different. What he or she will gel with and how much exercise should be given, you cannot do that on day one. You have to give them the principles and say, go to a senior physiotherapist. You start off and you come back and talk to me again as to what is happening. Some of them feel miserable after doing exercises. They feel more fatigued. So again, we come back to the same point. Every patient is different. And the doctor-patient relationship is important as to how much, which one, how often. So I think it's so variable. Yeah.
Before I move on to the medicinal treatment, there is always a question, can diet make a difference? And when patients go on to Google, they come back with wonder food like turmeric, which is supposed to be beneficial because they say it keeps all the toxins away. And then one amongst them, as in caffeine, which is usually asked to stop, is found to be beneficial to some extent in Parkinson's patients. Dr. Bhatt, diet and Parkinson's.
Okay.
The debates.
So the bottom line is a good diet. A good balanced diet is what a patient requires. Do I tell patients to drink excessive coffee? No. But there is an epidemiological evidence that patients who have on large coffee intake have a lower prevalence of Parkinson's disease. But that does not relate to practice where you tell patients to start drinking coffee. So the most important thing is that patients should have a balanced diet. And this is very important. Those patients who start losing weight because of the disease, because of age, often tend to develop certain problems of like dyskinesia. So we need to tell them to put on weight. There are some patients who are excessively obese, and so they need to lose weight. There is also well-known established fact that prevalence of diabetes is very high among patients with Parkinson's disease. So it's very important they control their diabetes. So the diet would change for a diabetic patient, leave alone Parkinson's disease. So so control of diabetes, control of other features which can be controlled with diet, with whether it's your blood pressure, whether it's your blood sugar, controlling your thyroid very well. So diet has a very large role to play in keeping your health well. It has there's no specific diet that you need to take which helps directly Parkinson's disease management.
Why is diabetes having a higher prevalence amongst Parkinson's patients?
Nobody knows. But it is well established, epidemiologically well established, there's a high prevalence.
Right. Dr. Khadilkar, anything that you'd like to add?
Yeah, no, I just want to point out that the loss of weight seems to come in phases for them. Like they're going on okay, and the phase comes when they drop 3-4 kilos and they start wondering, and everyone starts wondering what's happening. They do the tests for weight loss and nothing is found. Then they stabilize again for a while. So loss of weight is definitely a part of the whole process of whatever is happening to them. And you need to definitely look at them. And like Dr. Bhatt said, when they're losing weight, they sometimes come back with more problems of extra movement. Yeah.
So falls and balance issues are quite common with them. How do they really cope up with this, and what's your advice?
Yeah. Can I take that?
Yes, sir. Dr. Khadilkar, I'm with you.
See, basically, the falls is a very important part of management, and often we don't pay enough attention to it because we are all tablet oriented. I mean, all doctors as well as patients, they want tablets, and quite often these other points are not discussed in depth except maybe specialty clinics. So for when they get up in the night to go and pass urine, that's when they fall. So I think they have to make sure that when they get up, they first sit for a while, then they stand, then they stabilize themselves, and once they feel confident and they're fully awake, then they start walking. Then some sort of light should be there in the bathroom as well as the path where they'll go from the bedroom to the bathroom. It's preferable to have railings they can hold on to. Furniture should be decluttered. Whatever furniture is there shouldn't have corners. Carpet is one option if it can be kept clean so that even if they fall, they don't hurt themselves so much. So good lighting, decluttering of the furniture, no points to the and holding points when they get up next to the bed are some of the things. But in some types of Parkinson's disease, they have such a propensity to fall that they just don't know when and why they fall, and they'll still drop down. So in these conditions, somebody to help them, sometimes because they fall back towards a walker with which moves the balance a little forward. But falls are so important because if they fall down and break their bone, then they have had it. Mm-hmm. Then the whole rehabilitation suffers, the quality of life goes down, and some of them permanently become at a lower level.
Yeah.
So to add to what Satish has said so well, falls is one of the questions that I always ask the patient. Have you had a fall? Are you falling? The reason is that that's an indication for me that I need to look at my prescription. Because sometimes patients may fall because they are slightly under-medicated and they need more drugs. So I am very hesitant to increase drugs. But the moment I hear a patient is falling, that is when I would not hesitate to up my prescription and give them more medication. Because a good medication can prevent falls. So falls are not a common feature of early Parkinson's disease. First 5, 7, 8 years, the patient will never fall. Even first 10 years may pass and nothing may happen. It is only after 10 years of the disease that a patient may fall. And so the moment a patient complains of falls, it is a big signal to me that I need to look at his medication. And that is where your exercise question, that previous question that you asked. Yes. So I would say that I would increase his medication. Then I would say, no, well, now you need to go to a physiotherapist and start doing counterbalance, walking exercises, occupational therapist who will help the patient to get up from bed, how to go to the bathroom, how to get into a car. All these things come into play to help patient maintain balance.
When so much is going on,
just to say that, as Dr. Bhatt pointed out, first few years patients of Parkinson's disease don't fall.
Mm-hmm.
So if you see fall as a symptom early on, it's a big red flag that something else is happening and the diagnosis should be reviewed. So early falls in the first year or 2 years is a big point to consider, that the diagnosis may not be correct. Yeah.
I see. I think it's a very relevant point. Pain is something that everyone fears. So, is Parkinson's associated with pain, Dr. Khadilkar?
Well, I don't know what I would say to that. Patients do complain of aches and pains, and they feel fatigued. These are two common symptoms which they perceive, but there's nothing that corroborates with that, I would say. So they do have aches and pains, they do complain, and exercise helps them in that regard. And they also say that they are fatigued simultaneously.
Right.
So they cannot do things. Mohit, anything you want to say?
So there are certain what I call as non-motor symptoms of Parkinson. Parkinson is a motor symptom. You have tremors, you are slow, but you also have non-motor symptoms, and pain is one of them. So they have vague aches and pains, usually thigh pains, usually calf pains. And pains at night. So that's an indication that the patient needs more medication. So if a patient is not giving a drug at the bedtime, they may wake up in the middle of the night with pains and aches. So that's why you bring in a medication just before the patient goes to bed. And even sometimes they have aches and pains in the daytime. So then you need to increase your drugs. Sometimes you need to give simple painkillers. So aches and pains are well known, especially in older patients with a longer disease duration.
So we have discussed
RLS. Do we touch on RLS here, Mohit?
Yes. So you can also have what Dr. Satish Khadilkar rightly pointed out is restless leg syndrome. It's a condition where patients feel restless when they go to bed. They feel creepy, crawly feeling on the feet. They need somebody to massage their legs. And there are medications which we give at night to treat this. It's very effectively treatable, very easily treatable. But it's very important to identify this symptom, because patients say, I can't sleep at night. There's something happening. I'm not comfortable. My legs are paining. My legs are aching. So then you have to analyze this symptom. And as Dr. Khadilkar said, it could be restless leg syndrome.
True, and restless leg syndrome is associated with so many other disorders as well, isn't it?
Yeah.
So we have been talking so much about nutrition, diet, pain, exercise, falls, but the question now is prevention. We have discussed other associated symptoms. We have discussed how to pick the early symptoms, how to see and manage the progression is all there. The question now is, do we have a good treatment for Parkinson's? And of course, we know there is a dopamine deficiency. We do have a drug called levodopa. Is that really a magic pin? Dr. Bhatt, over to you.
Well, one of the greatest in the Nobel Prize discovery is discovery of levodopa. Krochka has got the Nobel Prize for it. And so the importance of this discovery is that for the first time, a neurodegenerative disease of the brain had a biochemical abnormality and it could be treated. So it was discovered in 1960. And since then, patients' lives have changed. An average patient would live 9 years without levodopa before the discovery of levodopa. Today, after the discovery of levodopa, patients live a normal lifespan. So levodopa has made a big, big difference. So we have understood the biochemical mechanism. We understand the changes that take place in the brain. So the levodopa has made a huge difference to patients' quality of life and longevity of life. Apart from levodopa, there have been a lot of drugs that came out which help levodopa work better, which support the function of levodopa, like the dopamine agonist, the razagiline and selagiline, which are drugs which slow down the breaking down of levodopa in the brain. So the levodopa, that tablet that you take, works longer, is more effective. So there have been a lot of levodopa itself brought in all these peripheral mechanisms which would help its function better in the brain. So drugs have made a huge difference. That's why movement disorder is such an attractive subspecialty, because there's one subspecialty when you can really treat patients very well
and see the impact. But from whatever little that we also have a little knowledge about is that you are giving levodopa, but then there are these off time when the symptoms re-emerge between the doses, and then there are these newer drugs that we have come to know about, that is safinamide by the brand name Xadago, another one which is rasagiline, the ones that you mentioned. So how much of relevance and role and improvement do they fetch to the patient? Dr. Khadilkar.
See, basically, I think when you have a patient with idiopathic Parkinson's disease and you start off with levodopa, first few years, there is no problem. They do very well, their quality of life improves, and your drugs are working well and everything is okay. As time goes by, these issues come where the time taken for the effect to start gets longer. Mm-hmm. The time for which the effect is maintained becomes shorter. And then the patient gets these periods where there is no effect of the drug or very little effect of the drug. So they get frozen, they cannot move, all the symptoms that they had originally come back. So these are the off periods. So in Parkinson's disease with a certain duration, usually longer than 5 years or sometimes much longer than that, they develop this problem where they have on period and off period. And this is where all the different strategies are required. This is where actually a movement disorder specialist work comes as to how to manage them through the day. And that's where you have drugs that prolong the action of the levodopa, which you can, nowadays, the combinations available. And there are other drugs like safinamide. So these are problems of after a few years of diagnosis. But they regularly come.
There is levodopa now available in the inhaled form also. Inbreza is one amongst the brand names that we are aware of. Is it practical? Is it happening?
I haven't used it. Mohit may want.
No, I don't think it's available easily as a used drug. So it's in advanced stage of sort of establishing itself, but it's not available.
Can patients also say that there is, to treat low blood pressure in Parkinson's patients, there are drugs like droxidopa by the brand name Northera and Nuplazid, that is Primanserin. They are available. Are they also available to treat low blood pressure in Parkinson's?
Yeah. So let me just walk you through some of the drugs that are available. So low blood pressure and all those things are not a very common aspect of treatment of Parkinson's disease. Most patients with Parkinson's disease maintain a normal blood pressure. There are some patients who would develop low blood pressure, which can easily be treated. So I don't think low blood pressure is a big challenge in treating. But your original question of off-period, patients not having adequate control throughout the day is a huge challenge. And that is why you require a whole range of medications to treat them. So and there is one formula does not fit every patient. So when a patient comes to you, every patient has a different amount of disease, every patient has a different disability, every patient has a different attitude towards the disease. So there are some people who take it in their stride and they can live with small disability. Some people are very sensitive and they don't want slightest disability. They don't want to be slightest off. They want to remain on all the time. So then you require more frequent medication. If you don't give them, they'll take it on their own. So that's the challenge of treating patients with Parkinson's disease. So you have to create a formula for every patient, and every prescription therefore is very different. And that's where the art of medicine comes in. That when a person is sitting in front of you, you have to read that patient's mind. You have to read the understand of how the formula of the family functions to give him the prescription that would suit him the best. There are some people who just don't like to take tablets, and you really have to convince them that no, you need to take these tablets because that's for your good.
The next question they will always ask is there any food that I can take which will increase my dopamine naturally? Does anything exist?
No, nothing exists.
And again,
I mean, as regards the absorption of levodopa, if they don't take it with protein, it's absorbed better. So that's one advice that some people give. Also, our Indian patients don't like dosages to be increased. This we see in India all the time. That they will come and tell you about their symptoms. They'll say, I can't walk. They'll say, I can't. And say, okay, I will increase your drug. They say, no. That's a peculiar thing that I find. They at the end, they'll say, okay, I'll suffer it, but don't increase my drug.
I mean, I know, I mean, that is so common in India. The very fact that you have to take a medicine seems to be something which the mindset is so anti. I mean, there are people who will question the very relevance. There's a side effects exceed more than the benefits, and that's how it is, but can't help it. But beyond the magic pill, beyond levodopa, beyond the success that we have seen, comes DBS, deep brain stimulation. Dr. Bhatt, we know that you have worked intensely in this field. I myself have had the fortune of working in the same institution as you at Kokilaben Dhirubhai Ambani Hospital, and I did trot into the operation theatre once to see the procedure and was quite amazed that such things existed. But now, of course, DBS is a well-known treatment modality given to Parkinson's patients. So my question to you is, Dr. Bhatt, 2-3 questions together that I will ask you is really, when did DBS start and how successfully have we managed with this surgery to eliminate or reduce or put at bay the symptoms of Parkinson's? And when we talk about this procedure, you may like to also tell the audience here that exactly how long is the hospital stay, what kind of change do they expect? And I also did see you assess the patient during the procedure itself, that okay, now tell how much is it improved. You did test out certain movements at that time. Could you enlighten us about it?
Okay.
Actually, Mohit, weren't you the first one in
Yes,
India to start with
yes,
FRSH?
of course.
Yeah, long ago. I think the first department to start. Yeah.
1999 was the first patient who was operated. And since then, we have been involved with more than 200 patients. So 400 surgeries, we can say, right side, left side. So deep brain stimulation is a very interesting surgery. What we do is, I'll very simple put it, is that we make 2 holes over here, which are size of a 8 and a coin. And using stereotactic. Stereotaxy is reaching a spot in the brain using the combination of computers, MRI scans, and when we put the wires into the brain, we listen to the sound of the brain. The brain has a different sound as you go down. And when you reach your target, the brain sound changes. And so we implant this electrode in the brain, which comes out under the skin and is attached to a battery. And this is a battery which sends continuous current in the brain. The idea of sending the current in the brain into these targets in the brain is to change the signaling of the brain. It does not increase the dopamine in the brain, but it changes the signaling, which happens because of lack of dopamine. And this change of signaling gives benefit to the patient. The idea of putting these wires, so when we put the wires into the brain, the patient is wide awake. We just give local anesthesia. As you know, brain is an insensitive organ. If you chop somebody's brain, he will feel no pain. So when we put the wires into the brain, the patient does not feel any pain. And this is a patient who has tremors in the hands. The moment we hit the target and give a small current, the tremor goes away. The hands become steady. The hand that could not move, now with the current, they starts moving. So we see the improvement on the table. And there is this battery which starts giving current to the patients. And then, so the starting to end, it's a 10-day story in the hospital. Patient comes on a Monday. By Thursday, we do the surgeries. By next Tuesday or Wednesday, the patient goes home. The surgery is not painful at all. In fact, we don't even give general anesthesia. We give a very short anesthesia when we want to implant the battery. But otherwise, there is no long anesthesia. Next day, the patient is sitting, moving, eating. So it's not a very traumatic surgery. There is no blood, there's no excitement. You literally see nothing, because when we put the wires, you're listening to the computer and listening to the patient. So it's a very not a dramatic surgery at all, unlike the surgeries that Puja, you must be doing. So
I do IVF. I'm an
you
IVF
do IVF,
specialist.
yeah.
I bring in hope. I bring in happiness. I do surgeries which are very, very, very fine microscopic. So yeah, I don't do traumatic surgeries.
Okay,
But
fine. So we are in the same boat. We are in the same boat. Then.
Absolutely. I once met a patient's relative who was treated at our hospital itself, and he narrated a story which, his own story about his near and dear one who had a DBS, with the battery having run out, and the patient therefore being kind of, in a very, kind of off phase. So what happens then? Do we just replace the battery?
No. So there are two types of battery. There are batteries which have a fixed current, like a battery in our torch cell. When they run out, you need to change it. Usually they have a life to 5 to 7 years. But now the modern battery, but we do not encourage, we like to put rechargeable batteries. So you sit and charge it every Sunday. It's like taking a small charger, putting in front of your battery for half an hour, and the battery through the skin is charged, and patient then moves around for a month. So once a week charging, and so they don't run out. And these batteries have a very long life. They have 15-year life. And if your patient comes regularly, we check the life of the battery, and we come to know that the battery is now going to wear out. So we would tell in that case the patient that you need to change the battery. So what are the expectations? Patients would, the disease progress continues, so we can't stop the disease. Do the patients have better quality of life? Yes. Do they take lesser drugs? Yes. 50% reduction in drugs.
That's wonderful.
Much better quality of life. I would say it improves their longevity. They live longer, because sometimes we do surgery at an age when we know that drugs will not last this patient beyond a certain time, while the timely surgery would make them live longer. So yes, quality of life, length of life. Yes, of course.
So when does one...
Mohit, it seems to me that as years are going by, the DBS as an option is being brought up earlier and earlier.
Earlier, yeah.
If you want to make a comment on that, okay. Is that because our safety things have improved, or have we realized that it works better in early disease, or what are your comments on that?
Yeah, so what is called early stimulation. So we do not stimulate any patient for first 5 years of the disease, because if a patient does not have Parkinson, as you're mentioning, other diseases which look like Parkinson disease, they make their presence felt in the first 5 years. So you don't want to do DBS in a person who does not have Parkinson disease. The idea of bringing in early surgery is that surgery really helps quality of life. So your quality of life suddenly jumps up, your need for drugs goes down. So some of the side effects that you have related to large prescription patients do not suffer. So early stimulation is a very good alternative for patients. But remember one thing, that people do not like brain surgery. It's not a very happy feeling. People, the moment you talk of surgery, there is a huge negative reaction.
Surgery itself, people want to keep at bay, and this is exactly what I've been intending to ask you. I mean, there may be some objective criteria and some subjective criteria based on which you decide to, bring forth the topic of DBS to patients. Are there any such criteria per se?
Yes. Oh yes. So it's a very strong clinical judgment. But the moment patient is starting to having early problems with medication, as far as we know that this disease is going to progress, it is nothing in the world is going to take it away, and the patient is going to go through the rigmarole of advanced Parkinson disease. So the moment early symptoms, as you were mentioning, on-off phenomena, patient losing weight, patient cannot sustain a 24 hours despite using multiple drugs, patient having side effects of drugs. These are all objective criteria when we consider surgery.
So this year, today on April 11, when we are talking about World Parkinson's Day, there is of course a theme every year which is allocated. And the theme this year is about mental health in Parkinson's and Parkinson's care and support. But we have of course talked about mental health per se, haven't we? But when it comes to the family per se, the caregiver support per se. And we know that Dr. Bhatt, you are running a full-fledged society, and I myself have attended the functions that you have organized for awareness with a hall full of Parkinson's patients. Where exactly do the caregivers find themselves coping up with so many challenges with the health of the Parkinson's patient, besides, of course, the patient himself, Dr. Bhatt?
Well, the role of a caring spouse and a supportive family cannot be underestimated. The success of a patient with Parkinson's disease depends how supportive the family is. And the moment a diagnosis of Parkinson's disease is made in a family, the whole family gets affected. And as the disease progresses and as new symptoms appear and as new troubles that Parkinson's disease invites, supporting spouse is very important. It helps you alleviate depression. The spouse helps you with locomotion. The spouse helps you take you to the toilet, provide you with adequate nutrition, look after, and remember, when the patient with Parkinson's disease is less and less and also to prevent them from getting depressed. So to alleviate depression and create a happiness in the family, give hope to the family. So a strong, supportive spouse is a huge benefit to a patient with Parkinson's disease. I cannot overestimate the role of a spouse. Spouse is very important and a family, supportive family, children, brothers, sisters, friends, supportive friends. People should not look at patients with Parkinson's disease as in a negative way. It's just a disease. It is not a crime. And so the role of the society in helping these people, creating facilities for them in public spaces is very important.
Dr. Khadilkar, would you like to add something?
I just want to make one or two observations. One is that what came to my mind as Mohit was talking about the society. I think generally I find that people in the society want to help, they're very helpful, and they do not mind the patient's tremors and things. It's the patient who goes in that mode and doesn't want to, he sort of goes in his shell. So that's one thing that I have seen. And since I also work with muscular dystrophy as an illness and see young children getting it and adults getting it, another thing that I realize is that the spouse of a patient with Parkinson's disease is also an older person.
True. So
I think they can't go on and on and on. So therefore, a support system beyond the spouse has to be developed in disease like Parkinson's disease and dementias, vis-a-vis other diseases where young children are affected.
So as we come towards the close of this session now, where we have dwelled in detail about this disease and of course tried to find solutions wherein support system matters, compliance to drug matters, the hope of surgery is there, and so many more. For a disease which is becoming a forerunner amongst neurological disorders. But finally, my question to both the experts of neurology today on our panel is, what is the mantra behind tiding over or coping up with Parkinson's disease? Dr. Khadilkar.
Maybe let Mohit give his mantra first.
Okay, I'll give my mantra.
Mohit.
This is a very practiced mantra. One is...
So we are here to conquer Parkinson's.
How to conquer Parkinson's. So one is that the patient should, first of all, learn to accept the disease. Acceptance, well, if you fight it and don't accept it, it's a big problem. So that is where time spent with the doctor. Regular visits to the doctor. You cannot run away from the doctor. You must see the doctor regularly. You must take your pills regularly. The third is exercise. Regular exercise is extremely important. Looking after your general health and a supportive family and a spouse are the way to succeed and conquer this disease.
I just want to bring in a little philosophy here. See, basically, as the way medicine is and the way we have projected medicine and the way we interact with the non-medical people, there is a general feeling that medicine is really advanced and there is a lot that we can do. There is no doubt that there is a lot that we can do, and we have advanced every decade to decade. If you see, taking this example of Parkinson's disease, there is no doubt that we have advanced. But a point comes where what Mohit said becomes very relevant, that there has to be acceptance that this is an illness which is going to slowly progress. And that acceptance I find getting less and less because we have this image that a lot is done. While a lot is done, certainly a lot is done, we haven't reached a point where we can say, okay, this disease will go away. If you look at, if I look at my patients who are from a village background, who have less education, who are from a low socioeconomic background, their acceptance is far more. They consider it as an eventuality. They accept it and adjust to it. Whereas wealthier the person, more educated the person, more the facilities offered to the person, lesser the acceptance. So this is an observation. So I think acceptance is important, and that is where again we have to come back to the doctor and patient relationship. How the doctor is guiding that particular patient through all these years really has the final say on what will happen to the patient. You have to be supportive.
Our panelists,
you have to yourself be
bring
optimistic.
To your notice, our panelists, I need to bring to your notice, we have some questions in the chat box. There are a few of them. I will shoot the questions to you, but I will request a very short pointed answers to them. One question which has been put forth is, what is the best way to control tremors? A one-word answer, if any. Dr. Bhatt?
Drugs, medication.
Dr. Khadilkar?
Same, medication.
Second question to you, Dr. Khadilkar. Safe and cardiac-friendly medicines in patients of Parkinson's disease and dose adjustments in Parkinson patients of the same medicines.
It's very individualized. Very individualized. Yeah.
Dr. Bhatt?
There is no cardiac and Parkinson's disease are cardiac safe. So you have to adjust the drug dosage.
Our third question to Dr. Bhatt. A patient using Syndopa plus 4 tablets a day for the past 4 years, aged 69, and wants to reduce the dosage. Is it advisable?
If the patient needs it, he needs it. 4 doses after 6 years of Parkinson's disease is not a large dose.
Dr. Khadilkar?
Same. Reduction will be difficult.
Dr. Khadilkar, this question is to you. Our fourth question. How to titrate the dose of Primiprexol in a lady of 79 years with Parkinson for the past 4 years?
I think we should skip this question because every patient is different and answer to every patient's need will be different. Yeah.
Dr. Bhatt, are you in Tango? Singh?
Yeah, absolutely. I think these are very individual patient related and you can't generalize it in a forum.
I agree. Now, Dr. Bhatt, this question is to you. Amantadine in Parkinsonism.
So patients who have dyskinesia, these are extra movements of the body which happens with Parkinson's disease. We use amantadine. Very effective drug, very useful drug.
Dr. Khadilkar?
Yes, but you have to be careful because it has a capacity to induce some problems on its own. Yeah,
another
like
question. This is a case-based question to Dr. Khadilkar this time. So this lady is a known Parkinson's patient on treatment for the past 5 years. She has received...
Puja, case-based can we skip? It's not possible to answer case-based questions.
Of course I can. And this would then bring us to the end of the Q&A that they have put forth to us. It has been a very enriching evening today. April 11th, World Parkinson's Day for Awareness, surely has created a lot of awareness, at least for me, and I'm sure for the audience as well. Dr. Bhatt and Dr. Khadilkar, it's been a pleasure. I for sure do value wisdom and experience. And I do appreciate that medicine has moved on in terms of leaps and bounds, and success stories of leading a better quality life, and with the theme of mental health and support this year, has certainly been achieved for this particular disorder of Parkinson's disease. Before we close this discussion, I would like to give you both this particular platform to put in your last comment before we close the show. Dr. Khadilkar.
No, I think you sort of organized and managed it extremely well. I think we covered most questions pertaining to Parkinson's disease. I think as things are going on, new medicines are coming, new patterns of therapies are coming, and I think the coming years will definitely be better for patients. So let's all be optimistic.
Dr. Bhatt?
I think superb program. I think you, Puja, did a superb job. I think, and you covered all aspects of the disease from the beginning to the end. So I have full marks to you. And I think, as Satish has said, great hope for patients with Parkinson's disease. The research, what patients should feel hope that there's so much of billions of dollars are being spent on research to get down to the cause of Parkinson's disease. And I don't think we are too far away when we can crack what causes Parkinson's disease, and we treat it very early so that it does not progress. So there's great hope it's around the corner.
With this, we end the show today. I personally am an optimist, and I do look at rays of hope in every nook and corner of the world, not just disease that we are discussing today. I, Dr. Puja Dewan, your show host and moderator with the top panel experts, Dr. Mohit Bhatt and Dr. Satish Khadilkar, do take your leave. We'll see you soon with another health event. Thank you so much. Goodbye. Good evening. Stay safe.
Thank you. Thank you very much.